Rice, one of the things you and I have talked about extensively in different conversations over the years kind of is the inequity in clinical research.
Yes.
Right? It wasn't until the NIH Reauthorization Act of 1993, and to give one man credit, my dad, for signing it, that required trials that were receiving NIH funding to include women in an equitable manner. It wasn't until my mom was in the Senate that legislation was passed to require pediatric trials to include children. What do you think the consequences are of this?
Well, first let me say thank you to your parents for having the foresight to understand that advocacy is about really creating policy, right, that creates sustainability, and the Office of Research in Women's Health was a big deal. When we think about women's health, we have to think about it more holistically. It is way beyond our reproductive health. It is way beyond just menopause. And the only way that we will be able to understand those to introduce interventions are to include women in the studies. And to include women in the studies early on from a preventive mindset, we are all accountable to women's health. I am a reproductive endocrinologist and fertility specialist. None of you got here without a mother.
Good evening, and welcome to the Clinton Foundation. I am Nora Holloway, and I serve as Human Resource Director for the Clinton Foundation. Thank you so much for joining us for what we believe is an important and long overdue conversation about menopause. Sometimes we simply just don't talk about it enough, but I have good news for you. Once considered a taboo and a punchline for jokes, finally menopause has a seat at the table. Tonight, we're breaking the silence. This conversation is about empowerment, education, and living a healthy, more informed life before, during, and after menopause. The fact is this discussion was grown out of a conversation within an employee resource group at the Clinton Foundation, launched by Women in Midlife. Having a safe, supportive space to talk openly about menopause has really changed my life. We're here. You will hear from some of our members in the group via video tonight. And we are honored to welcome our guest, Dr. Sarah Berg. Dr. Berg is a pioneer in women's health, a board-certified OBGYN, a certified Menopause Society practitioner, and a founder of Self-40, a women's health education platform dedicated to evidence-based, accessible information. Our moderator tonight is our own Joy Secuban, who serves as the Foundation Chief Strategy and Programs in Arkansas. Before we begin, please join us in thanking our donors who made tonight possible. Let's give them a round of applause. Okay, if everyone can just silence your cell phone, and let's get this party started. I'll turn it over to Joy.
Thank you, Nora. And I want to give a shout out to Terilyn back there. She is part of the group, spearheads the ERG group for the Clinton Foundation for Women in Midlife. You're welcome. It's so great to have a space like that to talk about those issues. You know, women who are pregnant are given grace, and it's great that we have this group. And I also want to shout out the men that are in the audience, because this is something important to know as well, because we're just a very complicated health
in the most
system.
beautiful way.
In the most beautiful way, exactly. Anyway, so I want to get started. So how can you easily explain perimenopause, menopause, and postmenopause, and explain the difference between them in the easiest way?
This is a perfect starting point. And also, thank you so much for having me here. Thank you guys for being here. It is incredible you took time out of your middle of the week to come and listen about menopause. So thank you guys. Can we give a round of applause to you guys?
Yes.
So let's start with the naming, because I think this gets a lot of people and is a little tricky. And so we talk about perimenopause, menopause, postmenopause. But what I like to say is let's just call it the menopause transition, because they all kind of run one to the next. But if we're going to piece it out and work through it, perimenopause is the beginning. It's when you start having the changes that you're going to feel for probably the next decade. So it's not a short period of time. It's where, and the reason it's happening is because you were born with how many eggs you were ever going to have. You've got a bucket of them. And so when we get to our late 30s, the bucket is running low. So the hormones are having to work a little harder to bring them out and bring them to the surface. So your hormones that go to your brain that say, hey, it's around that time of the month, let's drop an egg, they're having to really huff and puff to make that happen. So as you get further and further down in the bucket, the hormones are kind of doing their own thing, trying to make that happen. So you go from having the steady state of hormone stream to maybe you having skyrocketing one day to flatlining the next day. And I know you know if you've been through this process. It is not an even keel, and it is not a progression or a slow grind. So again, that's happening for most women from 2 to 10 years. So it's a long process. And then menopause is just a day in your life. It is 12 months from your last period. And again, I know that gets more complicated if you've had a hysterectomy and you don't have periods anymore, but that's the definition it was given. Postmenopause is just the rest of your life, and that's 30 to 40% of your life. So you still have a lot going on for a long period of time. So it is not an end.
Thank you. So part of our ERG group, I had, some of them are in New York, some of them are, all across the country. And so we had some of them do a video question. So I want to, but Tara-Lynn is here, but I want Tara-Lynn to do the video. If we could play that question.
Hi, my name is Tara-Lynn Mays. I'm a part of the finance team here at the foundation. And my question is about environmental factors. Do you know if the environment that we grew up in or the environment that we live in affects the onset of perimenopause? Thank you.
That is a great question. There you are. Thank you for asking it. I appreciate it. And I think that's a great thing to put to light. So we think about menopause as a biologic issue, and it is. But the environment we grow up in and the environment we live in affect how we go through it, and also sometimes when we go through it. So the first one that comes to mind for me is smoking. So if you are a smoker, or if you live with a smoker, there is a likely chance you will go through menopause earlier than if you were not, and usually more severely. So it's just one more thing to add to the list of why most physicians say, please avoid, or all of them should, please avoid cigarettes and try to avoid being in households where there's a high exposure to it. And I think that's the number one that people don't really think about. They think about smoking for lung disease, but they don't think about all the ways it affects other parts of their body and other parts of their health. Another one is sleep. So again, we know, and we'll talk about this, perimenopause and menopause affects our sleep, but there's a lot of other things we do before and during that could be affecting our sleep as well. And I really want to hit with this one, thinking environmental, is people that work jobs that require them to be up all night. So shift working. There's actually studies out there that show, and they looked at nurses because nurses do a lot of shift working, and most nurses are female, that nurses who do shift work actually will likely go through menopause earlier. So we can take that and think about anyone who does shift work. And then for myself, being a little selfish, physicians that do a lot of call. So if you're taking call and getting a lot of broken sleep, that could also affect. And another one is this stage also runs into a lot of where people have young children. So they might still be getting up 2 or 3 times a night, or when your kids are sick and you're up with them all night, that can affect. And so if you do that chronically, that could affect your timeline for menopause. So not only affecting it during it, but when you get there. Another one we always want to think about is how you take care of your body, what you eat and what you put into it. So nutrition is something that's very undervalued in thinking about what we do for menopause care. If you eat healthy foods that you can pronounce, you're more likely going to have less residual effect. We know processed foods can definitely affect hot flashes, night sweats, how you feel. So trying to think about avoiding those, and that's a whole thing, and I know there's a lot behind that, but if you can, try to eat greens, fruits, lean proteins, just the things you were taught as a little kid, like eat the good stuff on your plate, don't eat the fast and easy stuff, but I have kids, I understand, sometimes you're just gonna eat the chicken nuggets, and they are delicious, but just try not to make it every night. And then the one I think that's most important is access to care. That's an environmental factor. If you live rurally and far away from care, you're not going to be able to go to that 5 to 7 doctor appointments most women talk about to even get the initial care that's going to be effective. And we know that on average, it takes women 5 to 7 visits before they get the diagnosis of perimenopause or menopause and start getting treatment. So if you live somewhere where you can't even get access to a doctor, that's going to make this 200 times harder. And so you're not going to be able to get the care that can lead to a better quality of life.
Yeah, I mean, for me, since I have, the mic, it took a year.
Yeah.
And I had to go to doctor to convince them that I know something is different. I just don't know what it is. And they were like, oh, you have your period, it's fine. Don't worry about it. Another doctor said, oh, just wait until you're done with your period. And I was like, I think that's too late. And then just getting the no's about, I want to test my hormones, and I would get a no. And it was just so defeating. I was just defeated, and because I know my body like better than anyone else. And so I think that's an important thing, is just you have to advocate for yourself, otherwise no one else will. And especially the ERG group, it was just helpful because I was able to find a doctor that finally listened to me. And I literally left that doctor and cried in the parking lot because I couldn't believe it. They were just like, oh yeah, you checked this and this and this. You're in the middle of perimenopause. And so that was a relief to finally hear the words, because it took me a year. So anyway, I want to go on to the next question. It was Perry, and she's also the other co-chair of our ERG group.
Hi, my name is Perry Chinalai, and I'm part of our Too Small to Fail program at the Clinton Foundation. My question is about partial hysterectomies and whether or not they accelerate the symptoms of perimenopause or affect the symptoms of perimenopause in any way. Thanks so much.
Okay, that's a great question. And I'm going to say that to all these because these are all going to be fabulous questions, so just apologies. It's going to happen. So I want to start with the idea of a partial hysterectomy because not everybody knows the medical terms, and so I want to make sure that we're all on the same page. So a lot of people call a hysterectomy a partial hysterectomy because we're just talking about taking the uterus out. But there can also be hysterectomies where you take the uterus, the fallopian tubes, and the ovaries out. So I believe what we're talking about here is the idea of just taking the uterus out. And just is a big word because that's a big surgery. But the idea is, well, your ovaries are where your estrogen and progesterone are produced, so how could taking the uterus out affect that? But it can. And the reason is because some of the blood supply that goes to the ovaries actually starts at the uterus. It's the uterine artery that takes you there. So when you decrease the blood supply, it can decrease the life of the ovaries. So a lot of women absolutely will have symptoms a little earlier and start this process earlier. And then they also don't have a uterus to say that they're having irregular bleeding, so it makes it even that much harder for them to get diagnosed because they could go through the rigmarole of all the other things it could be because they're like, well, I took care of my female issue, and so now I shouldn't be having problems. So it can get really scary for them because they know something's wrong, but they thought they already took care of that problem.
Okay, one more video question from Nora.
Hi, my name is Nora Holloway, Director of Human Resources at the Clinton Foundation. And my question is, if I have thyroid disease, how can I tell whether my symptoms are from my thyroid or from perimenopause? Thank you.
That is a complicated one and a common problem, because thyroid disease, and when we think of usually low thyroid or hypothyroid, often mirrors a lot of the symptoms of perimenopause, menopause. The brain fog, the weight changes, the joint aches, the menstrual changes. So it can get a little squirrely in the doctor's office. And so that's why sometimes this can take time, even if we are thinking this could be menopause. And that's actually why every woman should start getting their thyroid checked by the Preventative Task Force at 35 years old and have that done about every 5 years. And so if you've never had your thyroid checked, that's an important thing to know. So 35, at least every 5 years, more often if something's happening that makes you think, is this perimenopause? Is this my thyroid? And then a lot of times when you're having those symptoms, there's other things we should be thinking about as well, like iron deficiency, which can also mirror it. So a lot of times, your doctor is going to want to piece through these different things to see, is it perimenopause or is it this other thing that we really need to treat to make sure that you're as safe and healthy for as long as possible? But they often overlap and could both be happening at the same time. So you could start treating your thyroid, you think, I must not be on the right dose, and it be perimenopause on top of it. So yes, it's very complicated. We are, like you said, we are very complicated, but in the most beautiful way possible. You get me.
I totally get you. I see you. And I want to talk about my favorite subject, hormone replacement therapy. Because last November, the FDA removed black box warnings from many of the hormone replacement therapies, HRTs, regarding breast cancer, cardiovascular disease, and dementia, based on updated scientific evidence showing safety for many women. Because my first doctor told me I couldn't do it because of breast cancer. And then even the FDA commissioner, Dr. Marty McCary, has said the black box warnings on HRTs is an American tragedy and one of the biggest mistakes in modern medicine. So why is it so important to include as you transition into this new phase of your life?
So yes, it has been amazing, and I wish more people knew about it. How many people here, be honest, knew that this black box warning thing happened? Hands? Okay, good job, guys. But I talk about this a decent amount because I love talking about menopause and perimenopause, and a lot of people don't know this, and they tried to make a big production, but it takes a while for this news to get out there and really get rolling. So the biggest part of this is that for probably over a decade, we have known in the medical community that what we were getting that black box for was really overstated. So truthfully, it's not that we have a lot of new data, because when that study came out, everyone stopped looking at menopause at all, which was a major travesty. So we had the study that we thought was going to show everyone should be on estrogen, and they were doing it for cardiac reasons. So they thought, let's put women on it that are in their 60s that have cardiac issues and see what happens. Well, it imploded. And you got the person standing in front of the stage saying it caused breast cancer, it caused heart disease, everyone get off of it. And overnight, 80% of women stopped using hormone therapy. And then it took 25 years for us to look back at the research and go, hey, wait a second. The people that they were testing in the study aren't the people we usually start on hormone therapy. Because the people that we start on hormone therapy are just starting the journey. They're having the symptoms. They're not on the other side. And so the average age of the woman in the study was 63. And the average age of people we put on hormone therapy is in their 40s to early 50s. So not the same person. So when we looked at it again and we just pulled out the younger population, the results were totally different. And that's the thing I think we don't talk about, is that when we extract that from the same study, it's a whole different world. And the world is that we can tell it changes quality of life, it protects your bones, it definitely takes away those hot flashes or night sweats, which cause, again, more quality of life issues. So it is a very helpful medication in the right population. And I think that's the education we want to get out there, because only 4% of women that are good candidates for hormone therapy, because again, not everyone is, it's not a fix-all, it's not for everyone, but only 4% of them are on hormone therapy. 4. And so that's a lot of people out there struggling that may think it's not appropriate from them because either their doctor may be a little behind on the information, and we want to educate them so they know where we're coming from as people that are menopause specialists, and because they have heard it over and over that hormone therapy is bad, it'll cause cancer, it'll hurt their hearts, or they get the prescription, they go home, and then they feel a little bullied by their family members that will say, it's going to cause cancer. I can't believe you do that to yourself. Why would you put that in your body? And so I used to always tell people in the office, please go fill the prescription, start taking it, wait 2 or 3 weeks before you mention it to anyone else, because at that point, you're probably going to feel a lot better, and no matter what anyone says, they're not going to be able to rip that out of your hands anymore. So again, it is not for everyone. There are definitely people that should, and which is why you should have a conversation with your provider, but for a majority of people, it is an option. And I call my menopause toolkit, all the things you can do to help with menopause symptoms, I call it the hammer, because it's kind of useful in almost every situation. Now, there are other things you can use, and you can find other ways to get around the hammer, but the hammer's going to do the job pretty well for a lot of people.
So when is it too late to start HRTs?
So there is a too late, and there's a reason behind it. And am I okay talking about the reason?
Sure.
I love it. Okay. So
Friends here.
Exactly. Y'all want to hear why, right? It makes the stories land. So we put out parameters, and they're just parameters. It's a one-on-one with your doctor if it may be too late. But we say after you've been through menopause for 10 years or you're over 60. And that's if you weren't on hormones before. That's not saying at that age you have to stop hormones if you're on them. It's saying if you want to start them, you'd really want a good discussion about if it's a safe choice for you. And this is the reason why. And this is why the study was so scary. If you've not been on hormones for over a decade, the estrogen helps keep your blood vessels nice and flexible. It helps keep them loosey-goosey. I would say it's like a hose. Well, when you don't have the estrogen, your vessels stiffen and the plaque starts building up more quickly, which is why that's a scary time. But then if you give yourself back estrogen after that, your vessels are going to try to loosen up, and then what's going to happen to that plaque? It's going to go somewhere you don't want it to go. So there is a reason why we have to be more careful if you've gone a while without estrogen and want to get back on it. But it really depends on who you are and what your symptoms are and what your heart factors are if you could be someone that could get back on it later.
Okay. So if you started like in your 30s, how long can you safely remain on it?
Possibly forever.
Okay.
Yeah, and that's another one. There used to be the phrase, lowest dose, shortest amount of time, and I sadly said that all the time in the office because we thought that's what was right. But again, as we're learning, you don't necessarily have to come off of it. And for a lot of people, as soon as you come off of it, all the things that put you on it start back up again. And one of the big ones is your bone health. So as soon as you come off estrogen supplementation, your bones will go right back into the breakdown way more than they build up cycle, which is one of the things we're trying to prevent. So no, you don't have to be on it forever, but also no, you don't have to get off of it. It's very individual what you want to do.
Okay, so what are replacement options if you have a pre-existing condition and can't take HRTs?
Oh, there are tons.
Okay.
And that's a good thing is, again, hormone therapy is great. It's not for everyone. There's a toolbox, and there's multiple shelves of other options. And a couple of them are going to sound like we're trying to hit the wrong thing, but just stay with me. So the number one thing you'll hear, and you've probably had friends have this, they go to their doctor, they say they have menopause symptoms, and they're given an antidepressant. And in their head, they think, my doctor thinks that this is all in my head. But actually, antidepressants help with hot flashes. Not as well as hormone therapy, but it does. About 75% of the time, it can help with hot flashes. So you may be on it if it's not something you want to, if you're not into hormones, if that's not for you, if you're not a good candidate. Taking it not because it's all in your head, but because the receptors actually live in your head that cause the hot flashes. Another one is a medicine called gabapentin. And you may have heard it because people get it when they have nerve problems or if they have just had surgery where your doctor's trying to protect your nerves. And it works really well for night sweats and hot flashes. But I kind of think some of it is just because it's a really sleepy medicine and it kind of drugs you out, so it puts everyone to sleep. But it works, it's fine. And then, yeah, you could try it. And then there's new stuff that's just come out, which I think is so cool. They're called NK3 receptor antagonists. And you may have heard of one of them, Veoza. And then Bayer just came out with another one. I can't remember the name, but it's a pill version. And they are fabulous because they're working on the same place where the hot flash comes from, just the other side. So the hypothalamus, the part of your brain, which makes, that's where your temperature control is, and what's causing the hot flash, not having the estrogen come in can be part of the problem, but the signal out is the other part of the problem. So it is actually protecting the signal that goes out. So science is really cool. They're inventing these new things every day, and the more we talk about it, the more they're gonna make these amazing drugs that they've tested, that they've checked on, that we know the safety of, that can do wonderful things for you. And you may be able to use that with hormone therapy. So if you feel like you're not getting enough benefit, we've got other things you can do. I'm not done. The next thing is lifestyle, the way you live. And so I always say a lot of times we want to put a pill on it, we want to do an easy button, but how we live our life and how we treat our body matters. So I know if you've been on TikTok, Instagram, Facebook, anywhere on the internet, someone has told you you need to lift heavy weights and eat a ton of protein. They're overdoing it, but they are important. So lifting weights is important. We know we lose a lot of bone mass and muscle mass during this time period. So building muscle protects your bone. So that is an easy way, and it revs your metabolism. So wonderful benefits there. Eating, like we said before, trying to eat real food. The Mediterranean and DASH way of eating are fabulous ways to avoid trigger foods. And a lot of people have different trigger foods. So we hear about people with spicy foods getting hot flashes. Drinking alcohol can cause hot flashes and night sweats. I'm sorry, guys. Try a month without it. It will blow your mind. But eating a more stable diet can change the way we experience. And then sleeping, we'll talk about it over and over. Sleeping, if you can get good sleep, and of course some medicines help, some lifestyle ways help as well. Sleep can keep the cortisol down, so keep your body's stress level down so that you don't run into as many hot flashes and night sweats. And then we also have more out-of-the-box stuff. I mean, I'm telling you, there's like drawers coming out of this one. So the next one is cognitive behavioral therapy. And it's not saying, again, it's not saying there's something wrong with you, but actually this kind of training can help with hot flashes and how you sleep. So it's one of the #1 treatments for insomnia. And then clinical hypnotism. And you can do it through your phone. There are apps that do this. Because I thought to myself when I learned this, I was like, where am I gonna find a hypnotist? Who's gonna hypnotize me on a daily basis? But there are actually books on how to hypnotize yourself. You can learn on your significant other. Or there's actually videos that can go through that for you. And then another one is stellate ganglia block, which is you go to a pain specialist and they actually inject something in your neck. I'd say that's like a way down the list one, but for some people it can keep symptoms away for up to 3 months. So it's kind of a fancy pants one, but it's got good data behind it. So again, look at all that stuff you can be doing. And there's a lot of things you maybe have never heard about. So knowledge is power.
So I want to, if you could tell, you were sharing a story with Nora back there before we came out about why you decided to specialize in menopause. And if you could share that, because this is in your medical school training and all of that, that was mind-blowing. That's always been so mind-blowing for me. But can you share that?
Absolutely. So Nora, we were sitting backstage having an awesome conversation. Nora kind of looked at me, she goes, why did you pick this? You know, out of all the women's health, what was this? And I call it the slope shoulder event. So my patients coming year after year, they're, you know, a lawyer, they work at the checkout counter and they've, you know, loved their job for years, or they are the CEO of a company and they walk in proud and confident. And then one year they come in and literally their posture is this. They've rolled in on themselves. They are not who they were before. And almost inevitably, when we kind of dug into it, it was always that they had started some of the changes of perimenopause, menopause, didn't necessarily know what was going on, and felt like they weren't themselves, thought something was terribly wrong with them, didn't know who they were anymore, or thought this was the beginning of the end. And it was horrifying, because these are women that are, you know, we're not talking, again, I would say Google menopause, and you'll get a picture of an 80-year-old woman. But women that are going through this look just like you and I. They look just like you and I. And so we don't see ourselves in that, so we don't know to anticipate that's coming yet. And we also don't think that this could be happening in our late 30s, early 40s, so we think something else is going on. So after having conversation after conversation, I realized that I didn't know enough. And I realized I hadn't been taught enough about my patients' 30-40% of their life. And when we look at it from the statistics, most people that go into obstetrics and gynecology, aka women's health, here to care for all women of all ages, maybe get 3 hours of training on menopause in 4 years. 80 hours a week. So if you can tell, that's not a big percentage of what we're learning, and that's in women's health. So then imagine all your other doctors that you're going to with some of these symptoms because you're trying to figure it out. They likely got 0 hours. And then in medical school, I cannot remember if I got any time. It's been a while, but I doubt it was more than 1 hour. So it's an education on both sides. Your doctor maybe didn't have the information when they started treating you, which is not fair on you, and it's not fair on them. And so we are working to help that become a bigger part of their curriculum. So there are a lot of really passionate people working through the legislature to try to make that part of medical education for not just women's health, but all healthcare workers. And that's also allied healthcare workers. So your nurses, your PTs, your chiropractors, all of us. And so if we don't have that information, you end up in the situation you are where you have to see 5 to 6 doctors to get the answer. And it's not fair on either side. And again, we're talking about the people with access to care. If you can only go maybe to 1 appointment a year, how long is it going to take you to get that information you need, or have been down long enough for someone to take you seriously? So that became my passion. And so I decided to become a menopause specialist, which is a different certification. I took a course, and I learned so much. And it was wonderful, but it was a little bit terrifying, because then I go back and Monday morning quarterback what I used to say to people and cringe. So I say, know better, do better. And so that's what I'm trying to do now, is I'm trying to spread this information so you as a patient can learn and help educate others, educate yourself, but also so physicians can learn better, do better, and see that there is a gap in their education, and they can take the time to learn, educate, so they can do better as well.
So I think this really leads into the next question about the common misconceptions about perimenopause and menopause that you often need to correct.
Well, I think I've talked about a lot of them, but definitely reiterating is important. So one of them is that it is just a reproductive thing. And we hear that all the time, and people think when they go through menopause and perimenopause, they're just turning off their periods, maybe having a couple hot flashes, and that's the end of it. And it's not. Estrogen receptors are on almost every organ in your entire body, so it's a whole body situation. And a major one is your brain. So that's why you have the hot flushes, the night sweats, the brain fog, the verbal inability. I call it the word grabbing, where you see the word in the air and you use it a million times, and you just just can't find it. I mean, it's like me losing the word uterus. I use that sucker all day long, and it's been lost before. So,
But you taught when you talked to us, Terilyn and Perry and I, you taught us a good word, buffering.
yes.
Like I'm buffering, and I use it all the time now. I'm like, I'm buffering, just give me a second.
That makes me so
buffering.
happy. Yes.
I may do it tonight.
Yeah, and just say it. Give yourself the pause, the buffer. Just let people know. I just need a minute. I'm processing. We'll circle back to that, if you want to use your business speak. But it is a whole body event. And so it also is your joints. Like, people don't know. They get aches or their frozen shoulder, and they go to an orthopedic, and they get the rigmarole and spend $2 billion, and it was just a hormone thing. Your skin changes. It is due to hormones. I'm so sorry. Even just wounds getting better, it takes a lot longer. So you're a higher risk of infection. So, it's your heart. Let's go. Your gut. You may burp a little bit more. Things don't move as fast, so they stay up here a little longer. So you're going to have to change the way you do some things. But if you don't know and you think it's just a one-system thing, because that's all we talk about estrogen for, you're going to be so overwhelmed. So spread the news. Estrogen's everywhere. Everyone needs to know this. Another big misconception, I think, is that and I think Nora brought it up, and I thought that was great, it's something we don't talk about. Does anybody have someone in their family that watched Encanto a billion times, the movie? I know you did. Yeah. Well, so it's a movie, and it's We Don't Talk About Bruno. Do you remember that song? In my head, when people do the whisper about menopause, it brings me back to that song, We Don't Talk About Menopause. And I think that movie has a lot of wisdom, and I kind of make analogies all the time to it, but we need to talk about it. We need to say things out loud, because you will be shocked how many people are going through the exact same experience. So if you can be brave and say what's going on out loud, A, you may have saved someone else who thought they were alone and going through this alone, and B, you will be surprised how much support you receive. So say it out loud. Don't be quiet about it. Don't think it's something that you're not allowed to say. There's nothing ugly about menopause. It's just a stage in your life. How many more misconceptions? Because there's a lot. Oh, how long it lasts. And I've said this one, but a lot of people think they can just grit and bear it because they think of it, it's just a little stage. But we talked about it. It can be up to a decade of symptoms or longer. So I hate when people have thought they can just suffer through it. And also, it's something that if we don't treat, you may live the rest of your life in a different state. So you want to think about preventative care. And I am passionate about preventative care. And so what you do on the front end affects how we live on the other side. So don't think you just have to bear through it and get through it. Do what you can to protect your body for the next 30-40% of your life.
Yeah, because there's a documentary, I don't know if you've seen the M Factor, and it was on PBS, and then they're coming out with a second one. And I learned a lot from that, and how Alzheimer's, women that is like the number one for women. And so there's a connection between estrogen and progesterone, right?
And it's a big thing, and this is why so many women are scared when they start having these brain symptoms, because 2/3 of people that have Alzheimer's are female. And so they used to tell women, it's just because y'all live longer, so you have more time to get it. But no, we now know that it's brewing in our 40s and 50s, and we are 2/3 of the people that have this disease happen, and it's scary and horrible, and anyone who's lived through it knows that. Well, what we're trying to figure out is, it seems that if it's brewing in that time, and that's when all this is going on with our body, there's got to be a link. And so we're working I'm not a researcher. I just listen to the research and do what they tell me. But the smart researchers are doing amazing work in figuring out how these are connected and what we can do. But going back to that theory of when you should take hormone therapy and when you shouldn't, We know if you take it later on, we've got the vascular issues which affect our brain too, but if you take it earlier, we do see some changes on how the dementia feels. So we're wondering, and we don't have data to show it yet, but we're wondering if you start taking hormone therapy earlier, if it is protective down the road. So that's a learning game. I can't say one way or the other. We don't have the data yet, but it does make sense. So it's worth thinking about and just putting out in the universe.
Yeah. So the average retirement age for women are 62 to 63. However, women have been delaying retirement. Women with children have policies in place to allow them to work, and you're advocating to provide women in menopause the same kind of grace. Can you talk about your pilot program, Menopause at Work? Because isn't it also going to be a CGI commitment?
Yes, well,
Amazing.
I hope so.
Clinton Global Initiative.
Yeah, so I have been in the works with the Clinton Global Initiative because, if you can't tell, I'm passionate about women in menopause and menopause care and advocacy. And so one place I think you probably will notice, you spend a lot of your life at work. So in the workplace, that's where you're going to have a lot of those symptoms we've talked about. So my thought process is, and what I think is important, and there's so much, are y'all okay if we go through some statistics? Because numbers are fun sometimes, and this one could really hit you. So 1 million people go through menopause in the United States, start menopause every year. We are 45 to 52-year-olds, 75% of them are in the workforce. So that's saying 75% of women are going through menopause and dealing with symptoms while they're at work. And because of that, and because we don't talk about it very Bruno style, a lot of women think something is wrong with them. They aren't working at the level they used to. They feel they're letting the company down, or people in the company don't know what's going on because we're afraid to express what's going on inside of us because we don't think that's very corporate of us. And so 2 out of every 5 women either leave their job or think about leaving their job, and 25% disappear. So that is a lot of financial ramification for the person that's making those decisions and for the business that they're working for. So we know that women are hitting their peak years, that pivot into their best job ever. They've learned so much. They've been with the company for so long. They have robust data of what they're doing in the workplace, and then they shut down. And we know that shutdown costs $1.8 billion in just the United States of people feeling like they can't go into work, they have to do something else. So there's financial dollars behind this. So my interest and my desire is to bring what we're talking about here to the workplace, but not only teaching women what's happening with their body. I want to also be able to have separate conversations with the HR that may not know menopause. They may never go through menopause, but they're dealing with someone they can tell isn't working where they were before. And if they have that information, they could have that conversation in a completely different way, and it can be more proactive rather than a defensive, like, what's happened? Or, you're not working how you used to be. Your attitude's terrible. You're yelling at people. And they're like, no, I'm not. Maybe they are. But those kind of conversations could be a lot more productive. And then if your employer knows we know how amazing you are, but if your employer knows how much they're going to financially lose if you leave, they're going to work harder to keep you there. So if we can teach every level, you learn what's going on in your body, your HR and management learns that this is happening, just knowing what to do to help protect you, and your boss's boss's boss knows that they don't want you to leave because it's going to cost them a lot of money, it's helping every level. And another very selfish thing I love that if we bring it into the workplace is this might be the only way some women get to learn, because we know our insurance is based around our work life, and some women may not have the opportunity to go to the multiple doctor appointments, so this may be their only chance of learning. So I'm able to educate more women about this stage just by bringing it as a workplace wellness issue for all. So my desire is to bring this to companies, show them why it's worth their bottom dollar, but secretly be helping women be able to learn what's going with their body and keep more women in the workplace, because we know businesses do great when we're there. I have another data on that one. Businesses that have women in the C-suite are the top 30% earners of businesses that have no women in the C-suite. So we actually make the money. So remind them that.
Yes, let's clap for that. Yes. Okay, you mentioned just a few things like eating healthy, and I want to go to Karen's question, another video question. Karen is right over there, but she taped a video.
Hi, my name is Karen Strawn. I'm the Education Programs Manager at the Clinton Presidential Center, and I was wondering what type of supplements you should take during perimenopause and menopause. Thanks so much.
Okay, that's a great question. I said I'd say it over and over, but I mean it. That's a great question. So this is a question I get all the time, and it is something that I think there's a misunderstanding around it, and I would love to talk y'all through what I know. And you may already know this, but I think it's really interesting information. So supplements we're thinking of like magnesium supplements, vitamin D supplements. If you go into a store, there's usually a whole aisle of them. What isn't on the supplements is that to put a supplement out, you don't actually have to have any regulation on what's in the supplement. So, and I don't think this is enough information is put out there to the public about this. So wellness industry has done a really good job of making us think we have to put extra stuff in our body to live our best life during menopause. And it makes total sense because women feel like they're being disregarded by their doctor. They don't know what's going on with them. There's an advertiser on TikTok and they're telling them how this changed their world and that everyone needs to be on it. And you're like, okay, I'll try the $30. I'll throw it out there. Let me see what happens. This menopause blend may work. And so they have capitalized on this delta of information that we're living in. And so I always call it menopause marketing versus menopause medicine. And so the supplement industry has done a really good job of capturing that attention and trying to provide you something that may help, but may just be money you're flushing down the toilet. And you never know. Like, I mean, I can't say it's not helping, and I can't say it's not doing the best, but we do know when we've explored supplements, sometimes what is on the label isn't even in the medication. And the reason that happens is because this isn't regulated by the FDA. There's not an overseeing body that's making sure what you are sold is actually there. The marketer, so whoever makes it, just has to say, I did it right, I promise, I'm a really nice person, and I did what I said I was gonna do. And that's all that has to be in that supplement. So some companies are really trustworthy, and there's actually some that have the label USPS, and that means that they did the extra step, or the marketer's trying really hard and maybe had a secondary person look at it, but most of the supplements out there didn't do that because it cost them extra money. And so supplements also, they've been touted as being natural and healthy and close to your body, but we're seeing a surge in the medical field of liver toxicity secondary to supplements because you don't really know what's in there, and you may be taking a medicine that hits your liver a little bit, but if you're taking something else on top of it that your doctor may not know about or may not have in it what it's supposed to, that can really take a hit on your liver. So we're seeing a surge of it. There's actually tons of papers coming out. There's news reports, there's PSAs, but you have to be like me and in the crowd where my TikTok and Instagram is all about public service announcements. So you may not be getting it, so I'm bringing it to you here. So that's why it's one of those, I always say, if you can get it from your diet, go there first. And then there are people that you've had a surgery where you don't absorb well, so you may need a supplement, but you want to do the one that maybe has more research and your doctor is saying you actually need. And so anything that says it's a blend or a Mino Help or Mino Well or any of those, if I can offer you any advice, run the other way and use that $30 on the fruit section. So I know that's not a fun thing to hear, but I'm happy to talk to anyone and answer questions. If you're on anything, I would love to talk you through it. I'm not saying don't use them. I just say know what you're using and be cautious of what's going in your body.
So one of the things you mentioned was like protein, and I'm seeing a lot of the menopause marketing on fiber and the importance of fiber and all of these things. So is fiber also key?
So key.
Okay.
That's my favorite one, actually, and I can't believe I didn't mention it. Thank you.
You're welcome.
Everyone should use more fiber, and fiber is awesome. You don't need a supplement. You don't need a pill. Getting it from your diet is awesome, but most women get half of the fiber they need in their diet, and fiber not only helps your GI system, but a lot of your hormones get processed through your GI system, which is crazy and cool, and we're learning a lot about that, the GI connection with our endocrine system. But fiber is a really good way of helping preserve the feeling. So if you have estrogen in your system, it's going to keep the feel around a little longer. So fiber is good for your GI system, but it's also good for your endocrine system. So it's not overserved. I actually really like that. I mean, almost no one can overdose on fiber because no one takes anywhere near enough. So yes, take your fiber. It's awesome.
So what about, I've also heard, because when you're going through perimenopause, menopause, you have the visceral fat that you can't get rid of, and that causes heart disease and all of this other stuff. So I've seen where some doctors are saying you should get on GLP-1s to help get rid of that, along with HRTs. So what is your stance on that?
So it's not for everyone. Again, it's not a fix-all for everyone, but there are great candidates for GLP-1. And if you are a good candidate and not someone that just wants to lose 10 pounds because you don't like the way it looks, but if it's causing actual metabolic issues like you're pre-diabetic or diabetic, or your blood pressure is creeping up and your cholesterol is getting higher all around this time, then those are great reasons where you could consider that as a tool with hormone therapy. And the latest studies have shown that they work really well together. And it makes a lot of sense because your body is learning to process things more appropriately. And so you're using that hormone therapy as most beneficial as you possibly can. But it's not a fix-all. It's not for everyone, and don't feel like you have to go out and get on that medication. But if you and your doctor think it may be good in that situation, it's worth considering.
Yeah. Okay. So what advice would you give yourself if you're like 20 years old and you think, but what can you do now? What kind of advice would you to prepare for this phase in your life?
I love that. So it's not something that we're terrified about. It's something we're just thinking in the future. And so most 20-year-olds aren't thinking about menopause. It's way in the future. But I think the idea is treat your body like you actually like it. 20-year-olds sometimes maybe stay up till 3 o'clock in the morning, eat pizza for breakfast, not looking at anyone in particular. They feel they can do it because it hasn't started harming them yet. But when we learn bad habits early, they're harder to break. And then it feels more horrendous when the things that were normal ways and behaviors for us start backfiring in us. And they will, because we're not meant to live that way. If I can harp on things again, if we don't eat appropriately, if we don't sleep well, we are doing our body long-term harm. So starting to live the healthiest lifestyle, not the usual 20-year-old lifestyle, is a good way to start. And thinking about starting to lift things. It doesn't have to be super heavy, but lifting things that are heavier than their own body weight earlier, because we know after 24, our bones are already starting to be on the decline. So, because that's where we compare it to. When we're looking at your bone DEXA, if y'all know what that is, it's a bone scan to see how good your bones look. they are comparing you to a 24-year-old because that's your max age. So we want to do everything you can after 24 to protect your bones so they stay that 24 age. So starting to lift things so you're strengthening your bones then, so you're not having to do as much work on the tail end. Hydrating, drink water. I'm usually carrying around a water bottle. You can ask anyone that knows me. It's usually about the size of my body. And I think we should make that a comfortable thing. Carrying water around, actually hydrating, is so good for every part of our body. So starting early and having a good habit of having your jug with you is muy bueno.
So what about the weighted vests? You mentioned lifting weights, but also like walking with a weighted vest or running with a weighted vest. I would never run with a weighted vest, but I will walk. Yeah. But is that good for you as well? Again, it's all the menopause marketing.
It's a little menopause marketing, but for the right person, it could be a really cool way to do two things at once. What we worry about is that if you go from doing nothing to like hiking up a hill in a weighted vest, your spine is going to hate you. And so it's something, if you're already really physically active, you've been walking a lot, you have a weighted vest that you can slowly progress the weight up, that could be okay. But if you start from, and I've seen the funniest video on it, it's like every person in like a walking group, and each person, their weighted vest looks bigger and bigger and bigger until it looks like they're wearing almost a balloon of like heavy weight. But that's how some people start. They're like, oh, I should wear a weighted vest. I'm going to wear a 75-pound weighted vest. So you want to start slow and low and work up just like you do anything physically active. So I think that's a little bit of it. There's not enough information before you get the weighted vest to help you know how to wear the weighted vest. Yeah. But it's a lot of marketing.
Yeah. I fell for it.
Well, the Holderman family does an hilarious thing about how many menopause marketing thing is, and it's like the guy is standing on a shaky thing for his nervous system, and then he's wearing the red light thing over his face, and then he's got something to stimulate hair growth, and you're like, yep, seen all that on my feed, so yeah, it's out there.
Yeah, it is out there. Okay, so I loved that this conversation throughout it. I love that you were taking notes up front. And just know that you can get it on videotape tomorrow. We're taping this. So if you need to go back, if you missed something on your notes, we will have this on our YouTube website. But I loved how everybody was like the oohs and the ahs.
I know. It felt good.
It felt good.
It felt
real good.
It felt like y'all knew what we were talking about up here.
So is there anything that we're winding down here a little bit. Is there anything that we might have missed that you are curious about? Oh, yeah.
Yes. That is another very individual. And so that's why you might have heard it both ways, because it's depending on what the end result you're looking for. So I know early on we talked about perimenopause, and my analogy I use with perimenopause hormones is it's the stock market. It's up one day, it's down the other. So I could check your estrogen level one day and it be, say, 200, and then 3 hours later it could be 20. So it's really hard in that stage of your life to capture anything. And a lot of times it may come back looking normal, but you know it's not normal. You know what's going on in your body's not normal. So a lot of times, even if you check estrogen labs and progesterone labs and testosterone labs, and they come back looking fine, that doesn't mean you don't need or couldn't benefit from hormone therapy. So it can give us some information, but it shouldn't change if you get treatment or not. And I think that's a big quandary we hear out there is people say, oh, it's normal, so you don't need anything. And that's absolutely false. And I think that's where a lot of people get stuck because they got told it was normal, so they think it must be something else going on. But some levels, like, so say if you were put on a testosterone medication, we want to make sure that your testosterone level doesn't get too high, because there's a lot of side effects with testosterone if we get into the wrong level, including acne, hair growth where you don't want it, hair loss where you do want it, even voice deepening that doesn't go away. So we want to be very careful to keep it in an appropriate female level and not get supra, which means over the level you should be at as a female. So that's one that you do want to keep a closer eye on. So most physicians get you started on it, check where you started, and then check every 3 to 6 months until they get to a steady state, and then every 6 months to a year, we'll check it out. So, yeah.
Building on this question, though, what about establishing? Oh, hello. Do you recommend establishing a baseline for hormones? Like of course, I know the menopause marketing. I've listened to a lot of podcasts, and one of the things one of the guests said was establishing a baseline for hormone levels, like in your 20s. So you have that. So you should be tested then, and then you can, use that as you're getting older. Do you recommend that to patients or no?
Not necessarily, because again, when you're going through, even in the predictable time period, day to day, I would say if you want to see how fun and complicated we are, look at a chart of female hormones through the normal menstrual period. You've got 4 to 5 different hormones. Some are up, some are down. So if you don't necessarily know where you are in your cycle, it doesn't tell you a lot of if that hormone should be high or low, because naturally they're high and low in different parts of your cycle. So people will tell me, oh, I got my hormones checked when they're talking about something like polycystic ovarian syndrome or endometriosis or a syndrome where you're still having cycles possibly. And I was like, okay, so what day of your cycle did they check it on? And they go, oh, we didn't check it on a certain day. I was just there in the office and they checked. And I was like, did they know where you were in your cycle? And we're like, oh, no, I don't know where I am in my cycle. So that doesn't help you a lot, and it doesn't help them a lot. But sometimes it makes people think they're lacking things, but they could just be in the part of their cycle where it's supposed to be low at that point. So if you know where you are in your cycle, it could be beneficial just to get a baseline. But if you're just checking to check, it's not going to tell you a lot.
And you have your information table out there. So if you want to talk about that.
Oh, yes. Thank you for bringing that up.
Yeah, of course.
So I wanted you guys to be able to, if you're interested, learn more about what I'm doing, learn more about how you can get in touch with me, learn if you're interested in the menopause in the workplace, how you can inquire about what I'm doing, what the process is. So I put little QR codes on there so that you can easily link to my website. You can learn about my Instagram. I write a lot, so I'm on Katie Couric Media. I've written in Parents Magazine. I write for a group called Unbiased Science. So I really try to get out there to help inform you what's going on, and I try to hit hot topics of what's in the news so that you can hear that hot topic and maybe get a little evidence behind it, either the good, the bad, the ugly. It's nice to have a place to go where you're like, she's not selling me a supplement. She's not selling me a weighted vest. She just really wants me to know what's going on. And that's what I want to bring you guys. And so share that with your friends. Share this with your significant other. They may need to know what's going on. This is not a female problem. This is an everyone informative place. Because every woman who lives to a certain age will go through menopause, unlike a lot of other things in women's health. So this is not niche, this is universal. So the more educated we are, the more educated the people that love us are, the less friction we're gonna have in our life when we get there. And when we get to what I call the best years of our life, not the ending, the best years. So I have information out there with QR codes just in case things are all taken. There's still the QR codes. Please check in. I want to hear from you. I am so happy you're here with us, and I appreciate y'all taking your time out of your busy Thursday to come just chat about menopause.
So I just want to thank you, Dr. Sarah Berg, for coming out here and having this conversation. I've been dying to have this conversation on this stage. Because I think it's really important, especially because it's not taught in medical school, and we have a lot to learn to help advocate for ourselves when we're in those doctors' offices, and you have to remember to get that first, second, third, and fourth opinion. Just keep advocating for yourself. So just a reminder, eat healthy.
Eat healthy. Hormones aren't bad.
Yeah, sleep. Get your thyroid checked if you're 35 every 5 years. Yeah, and what was that for supplements? Just to make sure it was
USPS.
Okay,
is
just like the post office. Okay, got it.
Yeah, it is just saying they didn't just check themselves and said it looked good. They had a company come in and say, oh, they also thought it looked good. It's not like FDA, but it's still it's much better than just saying, I made it, so I think it's fabulous. Just something to think about.
Yeah, that's really helpful. I didn't know that.
Yeah.
So thank you. I hope all of you had one of those moments tonight because we want to empower you to be better advocates for yourselves. So thank you again. Thank you for coming. Appreciate it.
Thank you so much for having me. I really, it's such a joy to talk to Joy.
Oh, thanks.